Hello everyone. I'm going to briefly go over BVM ventilation and just provide a short refresher. First, let's go over how the BVM should be configured and set up. Regardless of the configuration, the goal is for the inline end-tidal CO2 to be more proximal to the BVM or behind the filter so that the filter protects the inline filter, so that the viral filter protects the inline end-tidal CO2 from getting contaminated while you're ventilating with the BVM. Also, you'll note that the PEEP valve is preloaded. Make sure that if the patient is in cardiac arrest, that the PEEP is 5 or less. We don't want higher PEEP levels on patients who have circulatory or hemodynamic compromise. Okay, so one of the first steps when preparing your patient for BVM ventilation is to properly position them. We do that by placing them in ear to sternal notch, which means the ear hole should be in line with the neck hole, or the notch right above the sternum, i.e. the suprasternal notch, so ear to sternal notch. This is most easily achieved by using the CPR pillow. Notice on this mannequin, we have this steeper part against the shoulders, which is recommended. Do not place it this way. It might seem like it should go this way, but it should not. The steep part against the shoulders, that should mostly align the ear with the sternal notch. Okay. Now, obviously, we're going to use our airway adjuncts, but we're not going to go over that now. You should remember how to scissor the mouth open. You're not scissoring like this. I'm using the index finger. I'm going to do it on the lip so you can see index finger here, or pointer finger here, thumb here, and I'm pushing open on the teeth. That way if they bite down, my fingers can easily pop off. Okay, so next step is we're going to grab our BVM. We're going to put them on 15 liters. I'm going to remove this for now, maybe. We should put them on 15 liters per minute at least. You can't go higher if you need a higher concentration of oxygen. And I'm going to make sure that this bag is inflated. If the patient's not in cardiac arrest and we're prepared for DSI, RSI, or just having a patient that's hard to oxygenate, then we're going to put a standard nasal cannula on the patient, not an end-tidal nasal cannula. Okay, end-tidal nasal cannula, the oxygen comes out of the fenestrations in the top of the nasal cannula, not the prongs. The O2 does not come out of the prongs. The prongs are developed for sampling CO2. Okay, now there are different ways that you can obtain a mask seal. If you must do it with one hand, I'll demonstrate the best way. It would be, we're taught the CE method, which is something like this, okay? But the problem with the CE method is, you see I'm putting all the pressure on one side of the face and I have a big gap here, all right? I would recommend that you put it in the V of your arm and grab the tip of the chin and pull the chin into the mask, okay? But even better is doing two-handed thumbs down ventilation, which looks something like this. I've got the thumbs on the outer edge of the mask, okay? I'm grabbing the angle of the mandible and I'm performing a jaw thrust. Now people might want to do this, but here's the problem with this. You'll see when I do that, I'm actually bending the mask and I could create leaks. So this is often a two-person job where one person holds the mask and one person squeezes the BVM. But because of our elbow here, I can do it with, I can do one person, two-handed BVM ventilations like so. Okay. Now, to confirm that our BVM ventilations are effective, obviously we look for an end-tidal or a end-tidal CO2 waveform on the monitor. If you are ventilating and you're not getting an end-tidal waveform, then you go through your dope mnemonic. So displacement obstruction, pneumothorax, or equipment failure. Okay, so what I'm thinking is that there could be an obstruction because the patient's either not positioned properly. If there's equipment failure, I'm thinking that maybe maybe there's a leak. Okay, maybe my seal is not good. So I'm going to make sure I have a good seal. I'm going to reposition the patient. I'm going to attempt BVM ventilations again. All right. If I still don't have end-tidal CO2, it could be because the PEEP is too low. When the PEEP's too low, it prevents the oxygen from the lungs from going through the sensor. The oxygen will instead, because there's resistance against the flow in that direction, oxygen would preferentially leak from around the mask or wherever else the leak might be. So always make sure your PEEP valve is not riding down, and make sure you have a good seal. Make sure the patient's properly positioned. Use your airway adjuncts, but do not assume that you're not getting end-tidal CO2 because the monitor's just not picking it up, because that doesn't make sense. The monitor not picking it up is not an explanation for not getting end-tidal CO2. Okay. Now, I do want to go over how to test the suction, because I've seen on more than one occasion that the suction is handed off and not functioning because it was not tested. All right. So you can preload this, pre-connect it, all right, and stow it in the side here. I have seen the suction tubing connected here, all right, and not on the thicker, straighter part. The problem with connecting it here is, well, one, this is designed to follow the curvature of the tongue and the mouth, but also there are these holes, these fenestrations here, that will prevent this, in most cases, from suctioning up tissue. So if this gets occluded, then it's just not going to try to suck up all the airway tissue. But also, if this does get occluded, then some small fluid can still be suctioned through these little holes. So make sure that's connected properly. Make sure all the caps are secured at the top. When I test this, I'm going to turn it on, and this has a digital gauge, whereas the fixed unit in your truck has more of an analog gauge with a number. This is adjusted by turning the knob, and I test it. You see we're not drawing much back in here. I can't really test it by putting my hand over the tip. So I have to test it by occluding the tubing here. You can see that the vacuum is going up, and if I want more vacuum, then I'll just turn it up. You can see how it's going up. So always make sure you test your suction catheter. All right, I hope that was helpful, and thank you.